whatever is I'm doing, whether it is right or not. And it's such a privilege for us from the desk of Pune Obstetric and Gynecological Society to associate with Gwalior and Bhopal and MPOX, all MP OBGY Society. And we are so happy to have Madam Dr. Rosa Ulai here with us as the guest of honor, along with Dr. Kavita Singh, Madam, who is the Dean of GMC Bhopal. Such a huge post. I hope she can join in. And of course, very, very happy to have over here Dr. Snehlata Dubey, Dr. Dipti Gupta, Madam, Dr. Preeti Gupta, and Dr. Jigyasa, and Dr. Anju Verma as the next speaker. And Dr. Minakshi Deshpande also will be having a talk. And Dr. Aarti Nimkar, the president of POGS, who let me continue this particular cutting edge webinar. So, Rosa Madam, we started this webinar 4 to 5, only two talks. And only two talks, 4 to 5. And this has been quite popular because it's like a mixed bag webinar that we are having. It is not just one subject. There is one on infertility, sometimes on endoscopy, also one on joyful motherhood. And, so we are making it for everybody who can attend this. And we have people joining from all over, even from UAE and sometimes from other countries, people are joining for this webinar. So thank you very much for honoring us. And Mr. Prasad, we can take the slide forward from here. And Sandhya, thank you for the complete coordination.
Good afternoon, ma'am. Meenu ma'am, good afternoon.
Good afternoon, Preeti ji.
Preeti is the Vice President of Gwalior Obstetric Gynec Society.
Hello,
ma'am.
Yes.
Good evening, Dr. Rosa ma'am.
Hello, how are you, Preeti?
I'm fine, ma'am.
So thank you, ma'am. Thank you, Meenu ma'am. Aarti ma'am has joined our president POGA. So I request her to say a few words. Aarti ma'am.
Maybe she's joined.
आरती मैडम, आप म्यूट पे हो.
अभी हो गया.
Yes. Yes. So Aarti madam is a very senior gynecologist. Now she's taken over the in charge of the president of this big POGS society. So yes, madam, please.
Over to you, Aarti ma'am, for a few words.
Yeah. I welcome you all for this cutting edge webinar with the Gwalior and Jabalpur of Gynec Society. And I am welcoming our guest of honor, Dr. Rosa, and the president of the Gwalior OBGYN Society, and Kavita Singh, president and the GMC Bhopal. And Dr. Meenu is going to talk on the fertility enhancing surgeries, when not to do. That is very important. When not to do. Everybody is doing the surgery, but don't know the when not to. So it will be the bit eye-opening topic for everybody. And for her, chairpersons are the Snehlata Dubey and Dr. Dipti Gupta. Welcome you, ma'am, everybody. And Dr. Anju Verma is going to talk on the second, and Dipti Gupta and Josna Degra are the chairpersons for her, and one case presentation by Minakshi. So I think everybody will enjoy these topics and speakers. Welcome you all, and I request our moderator to start the webinar.
Yeah, thank you, ma'am. Thank you for your kind words. I request for a short prayer so that we can have an official inauguration of the webinar. Mr. Prasad, can you please play the prayer song?
Kurutvam kalyanam arogyam dhanasampadam shubham kurutvam kalyanam arogyam dhanasampadam शत्रुबुद्धि विनाशाय दीपज्योतिर्नमोस्तुते दीपज्योतिर्नमोस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, Mr. Prasad. Now I request Vaishali Savan ma'am to please officially introduce Rosa ma'am so that we can have few words from her.
Thank you, Sandhya. It is a great honor and privilege for me to give introduction of a guest of honor, Dr. Rosa Madam, today. And as you know, Dr. Rosa, we are really in awe of Rosa Madam's personality. She is truly beautiful in every way. You know, she's such a magnificent personality. And she is brilliant in academics. At the same time, she is a truly dazzling beauty, a beautiful person in every way. Rosa Madam, I remember you as chairperson when you were chairperson of Adolescent Committee and the great heights you took Adolescent Committee Foxy, and where you did exemplary work. And I also remember when you were going for vice president elections and you had come to Pune and all of us at Pune had supported you. And then you became vice president Foxy. And you have been doing wonderful, tremendous amount of work for Foxy, for Adolescent Committee. And going through Madam's biodata is like truly very impressive. She's truly a stalwart. She's director of Olai Hospital and Research Center. And she is right now president of Gwalior OBGY Society, chairperson SBC Madhya Pradesh 23-24, member of National Screening Committee Family Planning Association.
Vishali, thank you. Can I talk
Just
more?
few lines, ma'am, just few lines. Madam was Vice President Foxy 2014 and very impressive. Madam was FIGO representative WHO session at the FIGO World Congress at Rome 2012. And she is also WHO consultant expert panel meet for making global guidelines on adolescent sexual reproductive issues. She's won many awards and she has many publications. She's authored many books, co-authored many books and more than 100 publications. So, ma'am, we are truly impressed and thank you for being with us today. Welcome, ma'am.
Thank you, Vishali, for the very warm, introduction. Very good friend of mine. We've been together long, years back, Vishali, when we used to be traveling to Taiwan and a lot of international conferences. And I must say that Vishali was always a very good speaker, good faculty speaker. She's been always active throughout. I do remember those days. And you have been the past chairperson of the Parentology Committee. We would like to see you climb up the hierarchy in Foxy as well. So here we have, I see a lot of my, friends, Charulata. I can see you here. You are present as chairperson of the Study of Female Breast Committee. So lovely to see you here. And I know you're doing great work in your committee. Pune is very close to my heart. I studied in Panchgani. So you can imagine during my school days when I was there. So Pune was my, it was like my Maika, we say, in Hindi, it's my mother's land. And of course, I have great amount of friends who are from Pune. And, when I got the news that you are doing this beautiful webinar, I must congratulate Dr. Meenu Agrawal, who's been doing this and spearheading this program, taking, giving the torch to your present, I think Dr. Anita is taken over, Aarti is taken over as a president. So you will continue be doing this. That's a wonderful team because we always believe in teamwork. If you work in a team unitedly, you progress. And this society, Pune, has been progressing because of this. Madhya Pradesh too, we are doing great work. For your introduction, I'm so happy to have with us Jabalpur. I think the secretary is also here, Dr. Jekya Denga, who's here. And of course, Deepti is also a very active secretary, past secretary of this organization. Now she's taken over for AMPOC. Very proud of both of you. And of course, we are having my own society. We have the speaker today, Anju, he is here, and Dr. Deepti, who is the vice president. Snehlata is the secretary of Gwalior Obstetric Gynec Society. So I'm so glad that you all have joined in two societies from Madhya Pradesh. And it's a very good habit. In fact, we are also going to do that. You know, the societies learn from each other. We bring in the friendship. See, election is one part, but getting to know each other. Trust me, when I went for my chairmanships and vice president election, I made more friends, rather. So that love, unity, respect with all humility takes us to greater heights. So, Meenu, I wish you all the very best. I know it's nerve, it's going around, stress a lot, but enjoy what you're doing. That is what I would say. And congratulations again to the whole team. The topics you've taken are basics. That's why it is touching the hearts. We're talking about basics that all the fellow, Foxians can learn at the grassroots. So again, congratulations to you. I don't want to speak more because I think we would like to hear from Meenu. Your topic is first and then from Anju. Okay, all the very best to you and thank you so much inviting Gwalior and Jabalpur from Madhya Pradesh. I hope this has been telecasted and all the members of Madhya Pradesh societies can benefit from it. Thank you and over to you now.
Thank you, Rosa Madam, for these nice words of wisdom and your blessings. So thank you so much and very kind of you to be with us on this. And yes, Pune is still your Mica. So whenever you come here, we will treat you like our.
Thank you, Meenu.
Thank you.
Thank you, ma'am. Kavita Singh, ma'am, has not been able to join, but probably she would join in some time. But I still request Meenakshi, madam, our General Secretary, to please introduce her formally so that, we can, because she sent her blessings all the way, even if she is not joined as of now. So, Meenakshi, ma'am, can you please introduce her officially?
Okay. I think when she joins, we should introduce.
I think so. What to do?
Okay,
as a secretary, I'll welcome all the faculties and Dr. Rosa, madam, and Dr. Kavita Singh as our guest of honors today.
Ma'am, whatever you say, ma'am, we can.
I think I will just introduce her shortly and then we will move on.
Yes.
So, Dr. Kavita Singh, madam, who is one of our guests of honors today. So, she is Dean of GMC Bhopal and she is an ex-professor and head of Obstetric Gynec Department of Jabalpur. She's got quite a lot of teaching experience. She was president of Jabalpur Obstetric Gynec Society, president of Rotary Club of Jabalpur, secretary MP, organizing secretary AMPOGS, organizing secretary of AOGON. And her awards, she has got a national and academic service awards, which she has received are Foxy Duru Shah Community Service Award in 2023, Dr. Usha Saraiya Foxy ICOG Guest Lecture Award in 2012, Best Community Service Rotary Award in 2006 to 2013, Best Scientific Video Award at CEFOC Conference Agra in 2013, Dr. Kamini Rao and Dr. PC Daruwala Oration Award in 2007 and 2008. She's got about 39 publications. She's authored about 10 undergraduate, postgraduate textbooks. She's been a faculty in live workshops on 3 and a guest speaker in more than 75 lectures. So that's great. So we would welcome Dr. Kavita Singh, madam, as and when she joins. And yes, as blessings, if she has sent, Sandhya, if she has sent it in text, if you can read them out, then we can proceed with her.
I don't have it in text, ma'am, but yeah, probably she'll join in some time. So with this, we can officially move on to the first session. And for the first session, I invite the chairpersons, Dr. Snehalata Dubey and Dr. Deepti Gupta. And I request Meenakshi madam to introduce the first chairperson, that is Dr. Snehalata Dubey.
Yeah, can we have the slide? Thank you, Sandhya. Yeah. Dr. Snehalata Dubey, welcome. You are here. I can see you. She is MBBS MS from Gwalior. She is HOD BIMR Hospitals Gwalior and she is a laparoscopic surgeon and IVF and critical care specialist. She is a secretary of Gwalior Obs-Gynae Society presently and a vice president of NMO Gwalior. She is in charge of Garbha Sanskar and Arogya Bharati. She is a member of Foxy and many committees. 23 years of experience in the field of obstetrics and gynec. And she's a social activist. She's involved in BLS training, plantations, and meetings with elderly doctors. She has presented many papers in national and international conferences and many publications in national and international journals. So we welcome our chairperson, Dr. Snehalata Dubey.
Thank
Yeah, over to you, Dr. Sandhya, for your next chairperson.
Thank you, ma'am.
And I welcome all other faculties as well for this wonderful webinar, and we'll continue.
Yeah, thank you, ma'am, for the kind introduction of Snehalata, ma'am. I have the proud privilege to introduce Dr. Deepti Gupta. So she was a secretary Jabalpur OBGYN Society in last year 23-24.
Yeah.
She is secretary AMPOGS from 24 to 26 presently. She is the Foxy Quiz Committee West Zone Coordinator. She is the Foxy Gurukul Medha West Zone Coordinator. She is a peer reviewer of Jogi, co-editor of Foxy Focus on RPL. She is a contributor to Foxy GCP guidelines and clinical practice recommendations on obesity and pregnancy. She is MP ISAR and MP AGOI Executive Committee member, associate professor in Medical College in Jabalpur, consultant and unit head Ankur Fertility Clinic Jabalpur, 20 paper chapter publications. And apart from all these academic achievements that she has, I would really like to thank her, because during the organization of this webinar, she was the go-to person for me. I've troubled her at 12 o'clock at night for asking for details and CV. So thank you, Dr. Deepti. It is really a proud privilege and proud moment for me to introduce you. Welcome, Dr. Deepti.
Thank you so much. That's very sweet of you, Dr. Sandhya. It's a pleasure.
It was very
being
sweet
here.
of you to reply to all my queries. Thank you. And with this, I request Dr. Snehalata ma'am to please introduce our first speaker, none other than Dr. Meenu Agarwal.
Good evening, everybody. Dr. Meenu Agarwal needs no introduction. Still, I have to introduce her. She is the president of Pune Obstetrics and Gynecological Society. She is the elected Secretary General, International Society of Gynecological Endoscopy, Foxy Imaging Science Committee chairperson. She is a course director in endoscopy and ART training courses in UAE. She has over 12 publications in international journals. She is
Madam,
the first.
that's nice. Thank you.
She is the first author of 4 books and authored many chapters. And she is Bachelor in Reproductive Endoscopic Surgery certified. And she received many prestigious awards like India's Greatest Leaders by Asia One, Icons of Health by Times Group, Inspiring Gynecologist of West India by Health World, and Foxy, Champion of Foxy Award. Welcome, Dr. Meenu Agarwal.
Thank you. Thank you very much, Snehalata madam.
Thank you.
Kind introduction.
So
And
nice.
Deepti Gupta madam, always smiling. You know what I like about you, always smiling. So thank you so much. And I shall be now. I'll just share. So sorry. I'll just share my screen and to talk about the fertility enhancing procedures, when to do and when not to do. So good evening, everyone. And no, this topic is a little, I will just take it in a little different way, the fertility enhancing surgeries. Now, this is a huge burden. And as a doctor, not only on the doctor, but also on the patient. So what do the fertility enhancing surgery do to us, to the patient? One thing, we can diagnose and treat. Second thing is long-term management. Suppose she has endometriosis, or usko fibroid hai, so suppose she has other symptoms. So we are not just enhancing the fertility, we are also taking care of her other problems. Pain hai, bleeding hai, fibroid will go on increasing in size, the endometriosis may worsen. So we have to keep all these things in mind when we are performing a surgery. And why not to perform, again, we have to keep in mind. Now, what are the ASRM guidelines? ASRM guidelines very clearly say कि अगर IUI करना है patient का, then there is no role of diagnostic hysterol laparoscopy. Only 2 things we should have in hand. One is a good imaging. So excellent pelvic imaging report saying that, whatever we are looking for, for the surgery is not there. And second is the tubal patency test. So tubal patency we can do by HSG, by sonosalpingography, by hysterography. So all these methods we can use, but there is no role to do any laparoscopy or hysteroscopy for patients who are going in for IUI. All right. Now, ASHRAE guidelines went a step ahead. पहले हम लोग बोलते थे कि laparoscopy is the gold standard to treat or to diagnose endometriosis. This ASHRAE guidelines in 2022, what did they say? They said कि if the patient has the symptoms, suspected endometriosis, आपको अल्ट्रासाउंड पे लगता है कि you can empirically put her on medical management, and if she is feeling better with medical management, that means in the retrospect you have made a diagnosis of endometriosis. So suppose I get a young girl, say 17, 18-year-old girl, she has severe dysmenorrhea and she has a small endometriotic cyst on imaging lying there. We don't need to do a laparoscopy to confirm or to treat it. We can straight away take her for a medical management. Now, when we talk about infertility, now infertility in endometriosis will depend on what is the age of the lady, what is the duration of her infertility, whether she has any pain. Pain is one thing we have to always keep in mind. And what is whether it is a mild, moderate or severe endometriosis. Now, again, very clear guidelines. Suppose she has a mild to moderate endometriosis, she's young, or she has a good ovarian reserve. These are the patients maybe, and there is no other factor for infertility. And you think, अरे इसको endometriosis की वजह से pregnancy नहीं हो रहा है, AMH अच्छा है, everything else is fine. So that is the only group of patients, or she has severe pain, that you can go for a surgery. However, if she is older, or she does not have a good ovarian reserve, or she has got very severe endometriosis, do not touch these patients for any laparoscopy. You can straight counsel them, guide them in the right direction. So suppose we are doing a myomectomy for some patient, or suppose we have done a laparoscopy, maybe for for some other reason, and we find these are the peritoneal endometriotic patches. So what we can do is we can do a resection of these peritoneal patches that will give a good pain relief to the patient if she has pain. Now, this is not diagnosed on ultrasound most of the times. Suppose you find these small nodules sitting just scattered all over. Just two things we have to keep in mind. One is take a sponge on sponge holder and just push it into the posterior fornix. So you will see this small nodule sitting here, which we can coagulate. And also if there are nodules, make sure that these nodules, when you pick them up, they are superficial and it is not a deep infiltrating endometriosis. So whenever endometriosis is identified at laparoscopy, at that time clinicians are recommended to surgically treat it, as it is effective for reducing endometriosis pain. These are ASHRAE guidelines. This is what they say. Again, this second. Okay, now whether to do a drainage or to do an excision. Suppose you find an endometriotic cyst, there is no other cause for her infertility. She is young, she also has pain, and her ovarian reserve is good. So I'm again and again pressing that ovarian reserve is good. These are the patients we can operate. However, whether to go for a drainage or to go for an excision. Now, if we do drainage, the recurrence rate is high. If we do excision, the ovarian reserve will go down. So we are what to do. So what do the guidelines tell us? The guidelines tell us that these patients should, if at all you are operating, they should go for excision and not just for drainage. So in infertile women with endometrioma undergoing surgery, clinicians should perform excision of the endometrioma capsule instead of the drainage and electro. So these are I am only talking about the recommendation grading A, where they are sure what is the suggested guideline. So excision of the capsule instead of the drainage will give you a better pregnancy rates, again provided she is younger in age, she has no other factor of infertility, and her ovarian reserve is good. Now this is a 31-year-old lady. She is primary infertility for 3 years. Male factor is normal. Severe dysmenorrhea and dyspareunia. So these are the two factors which are there. Bilateral endometriomas, 3 cycles of IUI done outside. AMH is 2.9. We can see here. What next? Should we offer her surgery? Should we offer straight to go for an IVF? Again, the opinions can differ. I mean, I'm not saying that my opinion is the best opinion, but looking at the various guidelines, her AMH is good and she has pain. So I think these two factors will go in favor of surgery for this patient, followed by IUI for 2 or 3 cycles. And of course, if she does not conceive, then we always have to go for the other options. Now, this is the patient why not go for straight ART? Because we know that the presence of these endometriotic cyst in the ovary, they can reduce the fertility. And if we go for a surgical management, that will give us a better environment, and 30 to 40% of the patients will conceive after 8 months of the surgery. However, the patients where already they are low ovarian reserve, there do not operate, and we can go straight away for the ART. Now, a similar patient, same patient, but she is not married. She is 33 years. She is not married. She is sexually active. Dysmenorrhea, dyspareunia, bilateral endometrioma. We have to be careful in bilateral endometriomas whenever we are operating. First is, it should be a very, very skillful surgery. First is the best surgery. No, number 2. Number 3, if she's already had a surgery done at any time, do not operate on her again. So these are the things that we have to keep in mind. AMH is 2.9. Again, because of a severe dysmenorrhea and dyspareunia, I think this patient should be first tried with the medical management. If the medical management does not work, then we can always, second option would be a surgical management. And another thing which we have to keep in mind for this particular patient is the option of the freezing of her oocytes. The fertility preservation. She's 33 already, and we know that the presence of endometriotic cyst or the surgical, if at all she goes for a surgical management, that will reduce her ovarian reserve. So all these things, see, now when you discuss it with the patient, I have realized they understand and they are okay to go for fertility preservation. But sometimes earlier we used to feel, oh, how to tell the patient कि आपके eggs freeze कर लो, वो तो शादी भी नहीं हुई है अभी. But I think they are open, they are intelligent. The girls are very, with the Google, everything has changed. The level of knowledge is very, very high, and they accept it in a very nice way. So again, when we say AMH values, AMH, एक तो हमको don't do it 1 month later. Do it 3 months later, because suppose our surgery किया 1 month के बाद AMH falls, and after 3 months again it slightly goes up. So suppose today it is 2.9, I operate on her tomorrow, so I should repeat it after 3 months and counsel the patient that this is going to go down than the pre-operative values. Now again, अभी हम बोल रहे हैं कब नहीं सर्जरी करनी है. So suppose patient is for IVF and she has endometrioma. Should we operate? Should we not operate? She is for IVF or she is for ICSI for male factor infertility. एक 5 सेंटीमीटर या 6 सेंटीमीटर का एंडोमेट्रियोमा है वहां पर. So what do the RCTs tell us, or what do the guidelines tell us? Now here you see here treated versus intact endometrioma. Both IVF group, they found similar pregnancy outcome in both the groups. However, in the treated group, they took longer to conceive, lower antral follicle count, and a higher dose of FSH required. So you have reduced the ovarian reserve of the patient, and suppose she does not conceive, she does not have a lot of time in her hand because her ovarian reserve is already low. So there is no evidence to support surgical intervention before IVF, especially in advanced endometriosis. If the patient is for IVF or she has advanced endometriosis, her AMH is 1.2 or 1.5, she is 34 years of age, she is trying already for 4 years, it is better that we counsel the patient to straight go for IVF. अगेन एक आता है कि बहुत बड़ा एंडोमेट्रियोमा है तो शुड वी ऑपरेट, और छोटा है तो शुड वी लीव. नो, again, what do the ASHRAE guidelines tell? That even if the endometrioma is bigger than 3 centimeters, any size more than 3 centimeters, there is no evidence that cystectomy prior to treatment with ART improves pregnancy rates. So it is very, very clear. So I also sometimes patients tell you, अपने friends भी कभी call करके पूछते हैं कि 6 centimeters का endometrioma है, she is for IVF, should I operate on her? So when should we operate? Only if she is having severe pain or you have any doubt of malignancy. So those are the CA-125 is very high, and so you have a little doubt. So those are the patients you need to work them up better and maybe operate. So no evidence that any endometrioma treatment before ART increases the pregnancy rates. It does not. However, it actually reduces the ovarian reserve and it also reduces the ovarian response to the ovarian stimulation. So these things we have to keep in mind. तो कहाँ पर ऑपरेट कर सकते हैं? Only if it is a young patient, आपने 3-4 transfer already you have transferred, maybe 1, 2, 3, whatever, and she is not conceiving, she has large endometriomas, so you can probably consider that maybe I should check it out. Now this lady, 36 years old, married since 5 years, BMI 26, she has the 8 centimeters large endometriotic cyst. AMH was very, very low. So she went in for a donor oocyte. 2 बारी ET किया, दोनों बारी no pregnancy. Rest everything is normal. Again, should we operate on her or should we not operate on her? She had a relative in the US, and the relative advised her, who was a doctor, कि नहीं तुम surgery कराओ, तुम्हारा endometrioma की वजह से you are not getting pregnancy. She came to me and we discussed, and I told her, I said कि maybe statistically, and another thing I should tell to my जो भी थोड़े junior colleagues हैं यहाँ पर, कि immediately jump नहीं करना है. अगर आपने एक IVF cycle किया है, patient does not conceive, do not jump to finding the cause and treating the cause. Because suppose it is just statistically, आपको 60%, 70%, maybe up to 80% you are getting the result. So those many other patients will not conceive because it is statistically they are not falling in the group of becoming pregnant. Try again, right? The moment you put a finger to this could be the cause, you treat it, and if they don't conceive again, then somehow we lose face in front of the patient. तो इसमें so I told her, I said, in my opinion, I don't think this is the cause of your embryo not getting implanted. However, since she had more faith in her relative who was a doctor, we went ahead and we did a cystectomy for her. So simple cystectomy. We already had 5 blastocysts frozen for her for the from the donor egg. After that, what happens? Again, after the cystectomy, I did a transfer for her, and again we got a negative result. Third time, again a negative result. So we were again perplexed what to do. She went for the fourth cycle, and fortunately, she conceived in the fourth attempt. So sometimes it could just be that it is taking time for conceiving. So we need to individualize the treatment whenever we are doing any treatment for infertility. Then whenever we are going to do a pickup, you must, I mean, all of us now have become so experienced that we can do the pickup, avoiding anywhere the endometrioma is lying, we can avoid it and go ahead. Surgery only when the patient has pain or when you are suspecting any kind of a malignancy. So, adenomyosis, again, another thing, we did not know what to do with adenomyosis. So that was, abhi to surrogacy bhi nahi hai. Pehle to surrogacy, at least we had a little option of surrogacy. So that is again a difficult thing. Medical management, again, I would say best. Recently, we had a talk from Dr. Risad Pasik. He also very strongly advised medical management for adenomyosis and not to go for a surgical management. However, if at all patient is not responding, then a good surgery followed by a flap technique. What we are doing at our center, we are finding good results. We have 3 ongoing pregnancies with this adenomyotic surgery, and 1 or 2 have already delivered. So this can give you. Only thing is, do not overdo it. थोड़ा सा ही निकालो उसको, सिर्फ आपको डीबल्क करना है. अगर आप थोड़ा से भी डीप जाते, you get carried away, then you does not take too much of dissection to enter into the cavity. तो ये एक माइंड में हमेशा रखना है. Cavity is not very far, it is close, even if the uterus is very big in size. तो थोड़ा ही डीबल्क करना है, और डीबल्क करने के बाद use the barb suture. We use V-lock at our center, and then you close it in a flap-like manner. Minimum use of electrosurgery whenever we are doing whether the myomectomy or whether we are doing a adenomyosis surgery. So this we have to keep in mind that one moment. Okay, sorry. All right. अभी अगर हम मायोमेक्टमी कर रहे हैं ना, मायोमेक्टमी अगेन कब करना है? Only I think I'll be showing the slides later. Only 2 conditions. Either the fibroid is it is a submucous fibroid, or the fibroid is compressing on the endometrium. Intramural fibroid, subserous fibroid, never to operate. Intramural fibroids का थोड़ा plus minus है. There are some RCTs which have shown that removal of intramural fibroid improves the fertility. However, in practice, we find many times patients coming spontaneous pregnancy in spite of the presence of intramural fibroid. But if she also had a bad obstetric history, early pregnancy losses है उसको, infertility है, she has a 4 centimeters intramural fibroid, I think that is the fibroid we should remove. But suppose she has a infertility, 4 centimeters intramural fibroid, maybe male factor, not compressing on the endometrium, that fibroid need not be removed. So again, in the same fibroid, 4 centimeter, दोनों में intramural है, but if she has a history of any pregnancy losses, or the fibroid is compressing on the endometrium, those only need to be removed. Whenever the fibroid you are removing laparoscopically, what we do is we always, you can see here, this is the methylene blue that we are pushing from the cervix. So this is the methylene blue that we are pushing. We know that the cavity is open, does not matter. Only 2 things we have to keep in mind. One is go very close, go very close to the fibroid and push all the endometrium inside when you are suturing, and do not use any current over here. We did have a case where we had a pregnancy in the myomectomy scar ectopic, a very, very unusual case. We also published it, and this particular patient had a pregnancy post myomectomy, missed abortion, not managed, did not bleed with medical management, surgical management when we did evacuation, no products. Ultrasound was showing a sac in the cavity, in the intrauterine sac. We did a hysteroscopy pe kuch bhi nahi, and then we thought the pregnancy is in the myometrium scar ectopic. We treated it like a Cornwall pregnancy, and then we resected the whole thing. This was the first case of laparoscopically managed ectopic pregnancy. We actually published this case in 2017, and after that there was one more case by PG Paul sir. Very, very rare, unusual, but sometimes you can get these cases. एडनेक्सल मासिस, हाँ उनको तो ऑपरेट करना ही है, लेकिन उससे पहले वी मस्ट डू, कभी भी पेशेंट आया उसको एडनेक्सल मास है, लीव द फर्टिलिटी बिहाइंड. फर्स्ट मेक श्योर दैट देयर इज नो मैलिग्नेंसी, रूल दैट आउट, एंड एनी डर्मोइड सिस्ट शुड बी ऑपरेटेड. This should be operated before we go for the ART. So this I think I can just skip here. All right. Okay. All right. Okay. Bilateral hydrosalpinx, and the patient is for IVF. I think clear guidelines are there that this hydrosalpinx should be removed. However, some small tip. Kabhi hydrosalpinx is just lying very close to the bowel, and you cannot make out the distinction. So take methylene blue and just push methylene blue transcervically, and very clear, this is an easy case, but very clearly the tubes will be stained blue, and then you will know what is your plane of dissection for these cases. Isthmosil, again keep in mind always. Abhi kisi bhi patient who has a previous history of C-section, she's come for something else. You do a transvaginal sonography and you always look at the isthmus and see whether you can see the isthmosil, because 50-60% of isthmosil are asymptomatic. But why should you see it? Because then your eyes get used to looking for isthmosil. So then if you have a patient who has a post-menstrual spotting, bleeding, infertility, secondary infertility, then you can diagnose isthmosil. Again, all isthmosil do not, as I said, do not need to be operated unless you know that this is the cause for her infertility. And if this is the residual myometrium, if you see, this is the residual myometrium, okay? Only if the residual myometrium is less than 3 millimeters, then you have to go for a laparoscopic management for a thin scar. If it is more than 3 millimeters, good thickness of the myometrium, then simple hysteroscopically usko aap लेवल आउट कर सकते हो. सपोज उसको पोस्ट मेंस्ट्रुअल स्पॉटिंग है और कुछ इनफर्टिलिटी वगैरह कुछ नहीं है, एंड यू डोंट वांट टू यूज ए रिसेक्टोस्कोप देयर, तो सिर्फ एक शार्प क्यूरेट को डू इट एंटीरियरली एंड एट द लेवल ऑफ isthmus just make a few strokes and you will level it out, and then the menstrual blood will not collect there, and she will be relieved of her symptoms. So this is how the isthmosil surgery, hysteroscopic resection, as well as the laparoscopic management. Just a small tip in laparoscopic management when we are doing it, keep a dilator inside. So just push the bladder like we would push the bladder in a TLH or something. You see here, now this is the, sorry, one moment. Just 1 second. Yeah. So this is the dilator here. This is the dilator here. So keep the dilator in just at the level of internal os. Then you can very clearly see lower edge hai, ye upper edge hai. Just excise all the scar tissue, and then you close the anterior and posterior wall with the help of barb suture. I think is excellent because it gives a uniform strength all around. So again, as I said, this is a 26-year-old lady. She has 2 years ka infertility, and she has a submucosal fibroid. So submucosal fibroid, 1 centimeter ka, it should be removed before she goes for any ART treatment. Again, these fibroids, we can use a monopolar or a bipolar. Now, जो लोग नया खरीद रहे हैं, go for a bipolar. It is safer, and don't operate on bigger fibroids hysteroscopically when you're starting your practice, and slowly you can move to the advanced surgery. Again, I think I can just skip it. These are again FIGO 2 submucous fibroid. These you can have the option of going in for a laparoscopic. You can have the option of going in for a hysteroscopic. Here I have used a myoma screw and made from FIGO 2 to FIGO 1. So these options are also there. Now, suppose this lady, she is 33 years old. Everything is okay. She has an oligoasthenospermia and she has a 4 centimeters asymptomatic intramural fibroid. She has no menorrhagia, and this fibroid is not compressing on the endometrium. What to do for this patient? Should we remove the fibroid before her ICSI, or should we just do an ICSI with this fibroid in place? What do the guidelines say? The guidelines say that intramural fibroids, they decrease the fertility, but the result of the therapy are unclear. So we don't know. उसको निकालने के बाद pregnancy हो सकता है, fertility improve हो. However, we must counsel the patient that this fibroid can reduce your fertility when we are doing ICSI, or can cause an pregnancy loss when even if you conceive with the IVF. So knowing fully well that these things have been explained to the patient, what do the guidelines say? That do not touch this fibroid before the ART. But if she has the fibroid which is impinging into the cavity, those are the cases where again very clear, lot of RCT is telling us that whenever you have a submucosal component, then we may consider a myomectomy to improve the pregnancy rates. And a good mapping of the fibroid to tell which fibroids we are going to remove, which fibroids we are going to leave behind, because the patient should not come back and say, doc, you did my myomectomy and then you left. There are still 4 fibroids seen, because we did not counsel them that these 4 sitting subserous I am not going to remove. So to conclude, I would say again, at diagnostic VHL, कोई रोल नहीं है. Suppose आप hysteroscopy कर रहे हो before IVF, okay, और multiple implantation नहीं हुआ है उसको, and you find a polyp, you are going to remove it, right? So always write fertility enhancing laparoscopy or fertility enhancing hysteroscopy, because this is see and treat. Okay, so in a medical legal point of view, do not write a diagnostic hysteroscopy and then you write a polypectomy done. So these things are not accepted medical legally, because some patients can be really smart. Myomectomy only when it is indicated. Subserous fibroids do not touch. Intramural fibroids, very clear, unclear thing of removal. So that has to be kept. Submucous and fibroids sitting at the mucous endomyometrial junction, those should be treated. Endometriotic surgery, again, very important, that if the patient is for ART, for IVF, for any reason, do not touch the endometriomas. Also, if her AMH is poor or she's an older patient, do not touch the endometrioma. So that also should be kept in mind. Isthmocoel, all do not need to be operated, and we need to make a distinction of which patient should go for a hysteroscopic, which patient should go for a laparoscopic, or which patient can be just not to do anything. So thank you very much. And if there are any comments, they are welcome. Thank you so much.
Thank you, Meenu ma'am, for a very insightful lecture. When not to operate, when not to touch. Thank you. Any questions?
Congratulations, Meenu ma'am, for a beautiful talk. मतलब videos तो खैर थे ही बहुत शानदार.
And like I said in the beginning, मतलब अपने को मेडिकल प्रोफेशन में जो एक सिखाते थे हमेशा डिक्टम कि क्या करना है वो पता होना चाहिए, लेकिन क्या नहीं करना है और कब नहीं करना है ये भी पता होना चाहिए. So thank you so much, and I would like to express my gratitude once again to POGS President, respected Aarti Nimkar ma'am, Secretary Meenakshi Deshpande ma'am, of course Meenu ma'am and Vaishali ma'am, Charulata ma'am, my regards, Rosa ma'am, and all my MICA people, Preeti ma'am, Anju ma'am, Snehlata ma'am. It's been a pleasure. And Meenu ma'am, आपका talk सुन के I'm reminded of a quote from a famous pediatric neurosurgeon, Dr. Benjamin Carson. He said that a good surgeon doesn't just concentrate on technical ability, but also on the appropriateness of what you're doing. So thank you once again. Best wishes to you. And I will also like to take the opportunity to make a formal appeal to everybody to please support me in my dream of trying for the post of chairperson Foxy Quiz Committee. Thank you so much.
Thank you. Yes, thank you, Dr. Dipti. Many congratulations to you as well. And you are going for the chairperson post. All the best to you for the quiz committee chairperson.
Thank you, ma'am.
Nilesh is very fond of you. I know that.
Ma'am, sir ने बहुत सिखाया, and it's been a good experience working with him.
And thank you, Rosa madam, for मैंने आपको देखा तो मुझे लगा कि पता नहीं सब सही चल रहा है कि नहीं चल रहा है. तो
You spoke, Meenu, excellent. Beautiful. I was really enjoying your talk because I felt this is what the basics everybody should know. You put the latest ASHRAE guidelines so beautifully what one has to do. And I think with this, everybody can do infertility, especially with endometriosis, where now the ASHRAE guidelines talks about depression and taking care of anxiety of these patients who've got severe pain. So that was one aspect. I was really enjoying the talk, Meenakshi. Meenu, all the very best to you, and all the very best to you, Deepti. One of our shining stars in Madhya Pradesh. God willing, we'll have more coming up from Gwalior as well next year. But you go ahead this year, we'll support you.
Thank you,
And I
ma'am.
would also like to acknowledge Dr. Meenakshi Deshpande, Secretary of Pune Obstetric Gynec Society. I didn't see you in the beginning when I was talking. So thank you so much for all your wonderful activity, Meenu. Thanks for putting Gwalior together. And I think we'll go ahead and do more programs together once you become the Vice President. Thanks, 100%.
Thank you.
Yeah, we are with you. We will be with you. Thank you.
Thank you. Thank you, Rosa madam. Thank you.
Pleasure having you with us, Dr. Rosa. I think you had given us the date of 4th June. And yes, we could do it on 4th of June. And so we are so glad to have done it with Gwalior and Jabalpur. Thank you so much, ma'am. Thank you.
So with that, thank you, ma'am. With that, we move on to the next session. And for that, I invite the chairpersons, Dr. Preeti Gupta and Dr. Jigyasa Dhengra. And I request Charulata Bapa, ma'am, to please introduce our first chairperson, that is Dr. Preeti Gupta. Thank you, ma'am.
Thank you so much. It is always a pleasure to be in the Cutting Edge webinar where you meet friends and, the old friends and make new friends. And so here we have Dr. Preeti Gupta as one of our esteemed chairpersons. She's done her MBBS from Raj Medical College and MS also from the same college. She has a master's certificate course in reproductive medicine, fellowship in colposcopy, and a diploma in gynec endoscopy also. So she practices as an obstetrician and gynec ultrasound specialist, infertilologist, endoscopic surgeon.
Thank you, ma'am. Thanks a lot.
And she has the Youth Doctor Award to her name and the Anandibai Joshi Award also, which is a very, very prestigious award for doing great health work in rural communities and especially for the women. So welcome, Dr. Preeti.
Yeah, thank you, Charu ma'am, for such my introduction.
Yes, and our next chairperson for the session.
I request Dr. Meenakshi ma'am to please introduce Jigyasa ma'am.
Oh, hello. Thank you. Dr. Jigyasa Dhengra, are you here? We would like to welcome you to this webinar. Yes. Yeah, welcome. So she's a director and consultant at Mahi IVF and Women's Healthcare Center at Jabalpur. So very nice to meet faculties from Jabalpur, I mean, this is a very good way of connecting with long distance faculties and friends also. She's a secretary of Jabalpur Osgani Society presently, joint secretary in 23-24 and editor of the Jogs 23-24. Okay. She is the editor of Foxy West Zonal Conference with UA in 22, editor of RSSDI MP chapter in 2020, and publications in national and international journals. She's got plenty, book chapters in prestigious books. She's a special interest in high-risk pregnancy, NDVH, and infertility. She's life member of Foxy, IMS, IFS, ISAR, IAGE, and IMA. Member of Endocrine Committee of Foxy since 2021. So nice to meet you, Dr. Jiznasa, and welcome to this webinar.
Welcome, ma'am. I welcome both the prestigious chairpersons, and now I request Dr. Preeti Gupta, ma'am, to introduce our second speaker, Dr. Anju Verma, ma'am.
Sure. Dr. Anju is not only a IVF specialist, she is my one of the best friends, and we are batchmates also. She is having first IVF baby, first ICSI baby, and the first egg donation baby in the Gwalior Chambal region. And she is Vice President Gwalior at present 2024 and 25. She is Vice Chairperson MP Chapter ISAR. She is Organizing Secretary MP ISAR Conclave 2023. She had done MBBS from the Lucknow and the MS from the Gwalior GRMC Medical College. She was ex-assistant professor of the GR Medical College. At present, she is doing IVF practice since 2001. She is awarded FIGO in 2012 during the AICOG Varanasi. She is a life member of the ISAR, IFS, IMA, and the European Society of the Human Reproduction, the Embryology, and the ASRM. I welcome Dr. Anju Verma for her talk.
Thank you, dear Dr. Preeti Gupta, and for nice introduction. First of all, I would like to say thank you to our today's guest of honor, Dr. Rosa Oliai. She's also our GOGS president, for giving me this opportunity to being with you, all of you. And also would like to say thank you, Pune OBGY Society, to involving Gwalior Society in this wonderful webinar. So my today's talk is, I'm just sharing my screen. You can see?
Yes.
Hello.
Just have to make it full screen.
Yeah. So today's talk is just unexplained infertility, what's new? Everybody knows that infertility is idiopathic in the sense when causes remains unknown even after complete infertility workup. So what are the goals and objective of today's talk? To understand properly unexplained infertility, evaluate right diagnostic approach so that we can make the diagnosis of such type of cases of unexplained infertility when the patient is quite young. So after that diagnosis, we can do the management, whether we should do the expected management or we should do the active management. So by definition, we can see when the inability to conceive after 1 year with routine standard basic investigation of the infertility showing no abnormality means there is evidence of ovulation, adequate sperm count, fallopian tube patency positive, but patient is infertile. So we labeled this type of patient unexplained infertility. 30% of the patient unable to conceive have unexplained infertility. On the one side, we are saying that unexplained infertility having no cause. But on the other side, we are still trying to find out what may be the cause of unexplained infertility. Because these only 3 basic investigation, we couldn't get all the causes which may be lying behind. Unexplained infertility is a diagnosis of exclusion. To establish the diagnosis of unexplained infertility, clinicians should consider that was the infertility evaluation is complete, it is performed correctly, or it is interpreted appropriately or not. Because we know There may be ovulation confirmed, but even apparently normally ovulating women may produce poor type of the oocyte, so poor type of the embryo. Tubal patency may be positive in HSG, but always patent tube, not the always functional patent tube. There may be some abnormality in the functioning of the tube. Hemolysis may be normal, but fertilization capacity of the sperm may be affected. So when we try to find out the various causes of these three basic underlying basic investigation we usually do, we may find that in spite of ovulation, there are some ovarian endocrine factors which may produce abnormal type of the follicle growth. Luteinized unruptured follicle is one of the cause. Many patients think that there is progesterone rise. Patient is ovulatory, but there is LUF syndrome. There is hypersecretion of the LH, hypersecretion of prolactin in the presence of ovulation, reduced growth hormone sensitivity, cytologic or genetic abnormality in the oocytes, and there may be presence of antibodies to Juna pellucida which prevent fertilization. Some peritoneal factors cannot be detected. Even all the peritoneal factors cannot be detected by the simple histosalpingography. Some we can detect by putting the laparoscope, like mild endometriosis. But even putting the laparoscope, some factors usually we could not detect by the simple doing diagnostic laparoscopy, like altered macrophage immune activities, which is present in mild endometriosis all around. There may be presence of anticlamidal antibodies. Because nowadays, usually every gynecologist, especially infertility specialist, just putting the TVS. We are not putting the perispeculum examination to see the cervix. So we can't see the cervix in bed erosion, chronic cervicitis, which causes the altered cervical mucus. Just doing the one perispeculum examination, we can rule out that this is healthy cervix. By doing the postcoital test, we can detect that this mucus is healthy, which can allow the entry of the sperm. Otherwise, poor cervical mucus is one of the cause, which we labeled as unexplained infertility. Many endometrial factors may be found in the presence of good triple-line endometrium. There may be abnormal secretion of endometrial proteins, abnormal integral adhesion molecules in the endometrium, abnormal T cell or natural killer cell activity. There may be presence of endometrial fluid which creates secretions of embryotoxic factors. There may be poor uterine perfusion in spite of the good triple-line endometrium. One term is nowadays very much emerging, chronic endometritis. Chronic endometritis is a silent cause of the infertility and miscarriage. Chronic endometritis diagnosis, to make this diagnosis very challenging, it is usually asymptomatic condition. Many times it presents just a few atypical uterine bleeding, pelvic pain, leukorrhea, which is a very normal symptoms in a gynecological OPD. Even TVS examination, we cannot detect the diagnosis of chronic endometritis. Only very well done hysteroscopy, histopathology, and microbiology is used to make the diagnosis of endometritis. And just putting the few pictures by which, if we are doing very meticulous hysteroscopy, we can detect this may be the case of chronic endometritis, like hyperemia in the endometrial cavity, hyperemia and micropolyps in the endometrial cavity, micropolyposis, fluffy endometrium, and these are the strawberry spots, which usually find in cases of chronic endometritis. We can make the diagnosis of chronic endometritis by one is the hysteroscopy, then some markers by endometrial biopsy by immunohistochemistry, like CD138 marker and presence of the plasma cells in the stroma and endometrium. So these are the markers by which we can detect. Various panels are available nowadays, like DICE panel, which can detect this type of marker to making the help of this chronic endometritis. Then other marker for the natural, the uterine natural killer cells with CD56 marker, again by the immune histochemistry. Natural killer cells is a part of immune system, and these are the factors that play a key role in the conception. If these labels are deranged, then again cause implantation failure. and we can label it as early subclinical abortion as an unexplained infertility. Again, in male factors, in spite of the good number, there may be reduced count, reduced motility. There may be problem in acrosome reaction, so there is inability to zona binding with oocytes. And there may be few defect in the sperm head, which is not detected by the normal sperm morphology and analysis test. Because nowadays there is increased stress, oxidative stress, so much bad type of lifestyle, DNA sperm fragmentation cases are increased. If sperm DNA fragmentation index is high, such type of sperm is usually not able to fertilize the oocyte, so patients fail to conceive. A routine analysis with normal semen parameters within normal range may be elevated DNA fragmentation, which we could not find by the simple semen examination. Sperm DNA integrity is a crucial factor for fertilization process, embryo development, implantation, ongoing pregnancy, then live healthy offspring. Then, if there is formation of embryo, but it is poor quality of embryo, usually when we do IVF or ICSI, in cases of unexplained infertility, in many cases we see there is reduced progression to blastocyst in vitro culture. Many embryos get moral arrest. It is again because of the poor quality of the oocyte, poor quality oocyte, and poor quality of the sperm. So these few slides which till I talked about, these factors may or may not be definitely, because these are petitive, subtle, uncertain causes. As these some factors may be present in the fertile population also. But we must always consider these factors before just be labeling the patient unexplained infertility, and we counsel the patient that these are the basic tests. Many tests we could not see only this just by basic investigation. So when the patient say as to what is the cause, doctor, there is no abnormality, we say the patient, we should say there are many other causes which usually not detected by this simple test. Usually 4 common condition which find and we label the patient as unexplained infertility. These are the cases of mild endometriosis, which can be seen by just putting the laparoscope. Subtle tubal pathology, there may be kinking of the tube, peritubal adhesion, distorted peritubal relation of the tubes and ovary. So in spite of the ovulation, tube couldn't catch the egg. So it may be the cause of unexplained infertility. Premature ovarian aging and immunological fertility also is a very important cause. Nowadays, it is seen that fertility problems are frequently followed by the early menopause. These both are the expression of accelerated ovarian aging. The time interval between the onset of accelerated decline in fertility and menopause is 13 years. It is found in one study. On the basis of this fixed time interval of 13 years between the onset of accelerated decline of fertility and menopause, it can be speculated that women who become menopausal by the age of 45 years have experienced an accelerated decline in fertility around age of 32. Means at the age of 32, patient may face low ovarian reserve, low quality of the oocyte because of the early ovarian aging. So when we try to find out such type of patient of diminished ovarian reserve, it is usually seen by the elevated serum FSH level in early follicular phase. 5% of women with unexplained infertility have such type of elevated serum FSH level. Abnormality in the FSH and LH abnormalities is a cause because of the dysfunction of the pituitary ovarian axis. When there is poor folliculogenesis, there is altered estrogen-progesterone ratio, which again causes the problem in implantation and fertilization, with poor quality of the oocyte, so poor fertilization rate. It is seen that there is absent mid-cycle elevation of the hormone prolactin in unexplained infertility patient, which is usually present in a fertile population. When a study done in an asymptomatic group of the patient in epidemiological studies, it is shown that 10% of the women in the general population become menopausal by the age of 45. There is one study which shown that maternal menopause is a predictor of AMH and AFC count in daughters during reproductive age. Means, by the taking history of mother menopause, we can predict that this patient may be a case of early ovarian aging or accelerated decline of the infertility. So we catch these patients at the early age and we guide the patient for active management. Now we come to the management of unexplained infertility. Various plans of unexplained infertility is that first of foremost thing, it is empiric, means expectant management, because there is no cause. Patient is young, we can say just wait and watch. There is no obvious cause. But many things depend on the availability of the resources, patient's age, duration of infertility. The standard protocol is that it should be made like the progress from simple to complex. And there must be balance the effectiveness against the cost and the side effect. First thing in the management of the unexplained infertility, to counsel the patient to make a good lifestyle. There must be lifestyle modification. Alcohol should be avoided. Otherwise, it should be very, very limited consumption, per 1 unit per day. Smoking should be stopped, both maternal as well as paternal. Caffeine consumption less than 2 cups per day. There is too much intake of the caffeine nowadays, 10, 12 cups per day. Female body mass should be in the range. Neither the patient is too lean, neither the patient is too obese. Encourage the patient to keep the standard body mass index. For unexplained infertility, this is our duty to counsel the patient about the knowledge of fertile period. Many patients doesn't know the knowledge of the fertile period. So when we plan the strategy of the treatment, we should consider the 2 things only. One is the age and the duration of infertility. If female partner is less than 35 years and marital life is less than 2 years, we can allow the expectant management of 2 years. But if marital life is more than 2 years, even the patient is less than 35 years, we should counsel the patient for active management of unexplained infertility. When the patient is 35 to 39, we should encourage the patient just within few months or on only 1 year. Otherwise, we should allow the patient for active management. If it is 40 years, nowadays there are late marriages and patient come to around the 40 age and just say this, ma'am, our marital life is only 6 months, but patient is 40. At the age of 40, always the management, always active management, in spite of all the normal things. So we can say, it is, other than expectant management, treatment regime for unexplained infertility is just ovulation stimulation, ovarian stimulation, either with oral agent or injectable medicine, along with IUI or only just ovarian stimulation. If it fails, then advanced techniques like IVF and ICSI. When we should start? It is again repetition of the slide that if duration is more than 2 years or patient is 35 years, because prognosis is going to worse when the duration exceeds more than 3 years and female age is more than 35 years because of the rapid decline of the infertility. What is the purpose of superovulation and IUI in unexplained infertility? What is the aim? Because in natural fecundity in a natural pregnancy with timed intercourse is only 1.5 to 3%. To increase this conception rate, we allow the ovarian stimulation along with IUI, because ovarian stimulation and IUI improve the gamete quality, increase gamete number, and facilitate gamete interaction. By ovarian stimulation, we increase the not only number but also good quality of the oocyte. And at the time of when we give the trigger and we're doing IUI, that is increasing the density of motile sperm available to near the egg. No superiority between using letrozole or clomiphene in patients of unexplained infertility. It is studied. So we can use both of them drug. There is one term which is known as the fallopian tube sperm perfusion. In one study, it is seen that there is two terms. One is IUI and second is fallopian sperm perfusion. Fallopian sperm perfusion is nothing other than IUI. There is large volume of the prepared sperm. We flush in the uterine cavity and then the tubules. In IUI, we put the very, very less amount of the prepared sperm, 0.3 to 0.4 ml. But in fallopian sperm perfusion, around 2 to 3 ml. Many patients of unexplained infertility get more result than this type of the technique, fallopian tube sperm perfusion, than IUI. It is studied in one study group. Pregnancy rate is 27% with fallopian sperm perfusion, and IUI it is 8%. It is assumed that it is because of the flushing of the large volume of the inseminate washed sperm, which may be some mucus plugs, tubal obstruction, which may be deleterious to fertilization. This creates a good environment for the oocyte fertilization in unexplained infertility. These are some evidence-based approach which say expectant management may be comparable to clomiphene and timed intercourse or IUI. Means if patient is young, we can do expectant management with only ovulation induction or timed intercourse, or we can do also IUI. Both have the same results. It is pointed out that superovulation with clomiphene is more effective than letrozole. It is studied in cases of unexplained infertility. Again, gonadotropin seems to be more effective than both the clomiphene and letrozole, but again, they also have the greater chance of the multiple gestation. IVF is widely used nowadays, but it is not more effective than IUI with gonadotropin. It is one study, but some studies said that if we patient failed to conceive with IUI, with oral ovulations, we should not do many stimulations with gonadotropin. We should straightforward to jump in the IVF. So there are some few studies in point of favor of the gonadotropin IUI, few studies in favor of the direct going to the IVF if there is failure of the conception with only oral agents and IUI. These are some evidence of the ASRM guidelines that most couple, the best initial therapy is the 3 to 4 cycles of ovarian stimulation with oral medication or oral ovulations and IUI. If it fails, it should be followed by the IVF if there is unsuccessful of ovarian stimulation with IUI. But it is not recommended to perform only IUI in natural cycle for stress type of patient. There is no role of the natural cycle of IUI in unexplained infertility. Always should be combined with the ovarian stimulation with oral ovulations at least. There is insufficient evidence that treatment with low-dose gonadotropin with IUI is associated with higher pregnancy than clomiphene, cited letrozole and IUI. Means if we fails to stimulate or conceive the patient with IUI and oral ovulations, it is comparable again. If patients wants to low-cost effective treatment, we can say, okay, then now we have tried with the gonadotropin IUI. Otherwise, these type of patients should move forward to the IVF. Current evidence does not support IVF as a first-line therapy for unexplained infertility over expectant management if the patient is younger, less than 38 years. They should be provided ovarian stimulation IUI. It is recommended that couples with unexplained infertility initially undergo a course 3 to 4 cycle with IUI oral agent, though unsuccessful. Then IVF is recommended other than the IUI with gonadotropins. So we can conclude that semen analysis, ovulation testing, ovarian reserve assessment, and tubal patency assessment, uterine factor assessment. Before we can say the patient is unexplained infertility. It is more good rather than put the laparoscope to rule out the other tubal pathologies and endometriosis. We just not could say the patient is of unexplained infertility. Always do AMH and AFC count to see the decline in ovarian reserve. Expectant management, lifestyle change in a younger patient. Otherwise, controlled ovarian stimulation, IUI and IVF should be used in older patient. IVF always should be used. If IUI fail, it is a treatment of choice. So we can say the IVF is the treatment of choice in older patients or when the patient is failed to conceive with ovarian stimulation and IUI. Thank you.
Yeah, Dr. Anju, very, very, very nice talk. And so much you have explained in this one 20 minutes or 25 minutes. Excellent. Very, very nice. I'm sure
Thank
this
you,
is
ma'am.
very useful to everyone.
I want to know one question, Dr.
Yeah.
Anju. Is the DNA fragmentation test is compulsory in all the patients of the unexplained infertility?
It is advisable because we have to find out the some cause.
So
If
it is always to go for the DNA fragmentation test
If
in
facility
each and every
available,
patient?
if facility available, we must do.
Okay. And one thing more, in the cases of the chronic endometritis, without the hysteroscopic diagnosis, how can we diagnose it is a case of the chronic endometritis?
There are various endo panels are available. We can do the endometrial biopsy at around day 20. We can find out these plasma cells and CD130 markers, CD56. One is company's Life Cell is giving this opportunity by doing the DICE panel. There are 5 parameters along with this TB PCR for tuberculosis. All these parameters have studied. So we can find out all the things.
Thank you. Very nice topic. Thank you, Dr. Charu Appai ma'am, Dr. Meenu Agrawal ma'am, and our President, Dr. Rosa ma'am, and Secretary Dr. Snellata ma'am for giving me this opportunity. And it was really both topics were so good. And these are the eye-opener, particularly the fertility enhancing surgery, because so many patients come daily in routine having the fibroid with the infertility, and everybody suggests having the ovarian cyst, do the laparostro and everything, do the operation. And thank you, Dr. Anju. Maximum patients are coming of the unexplained infertility in the OPDs nowadays. Thanks a lot.
Thank you, ma'am. Now I request Jigyasa ma'am to please give her concluding remarks.
Yeah, it was very enlightening talk, madam. Anju madam, it was really very nice. You covered all the aspects unexplained in just 20 to 25 minutes. And I must say, in spite of all the advancement in the field of IVF and ART, unexplained infertility remains still a dilemma for all of us, for all the patients also, and for all of the clinicians and IVF specialists also. And we need many more further studies and further research in this field. Thank you, madam. Thank you. I'll thank all of you to make Jabalpur a part of the webinar, and thank you for everything.
I would like to thank Anju here for speaking so beautifully. Actually, Dr. Meenu, this is our very first webinar after we have been installed. So this is my team here, few of them. So I'm so happy that the big bang start was with all of them here. So thank you so much, Pune, for having us here with you, and Jabalpur, of course. And I wish again you, Meenu, all the best. Dr. Deepti Gupta from Jabalpur Quiz Committee. I'm sure we can support both of you here. Golia will be with both of you. Thank you so much.
Thank you, ma'am. But ma'am, please wait for some time. We have a short case presentation on augmentation of labor, and that's by Dr. Meenakshi Deshpande.
I'm with you. Yeah, I'm with you. I'm staying there.
Yes,
we are also with you.
Yes, ma'am. So I call upon Dr. Meenakshi Deshpande. I'll introduce her. Ma'am, please welcome. She is the POJ Secretary General this year. She was IMA Pune past president in 22-23. She's a senior consultant obstetrician and gynecologist practicing since 30 years as a high-risk pregnancy consultant. Director of Vatsalya Hospital, Sihagarh Road, and Krishna Hospital. She is a recipient of many awards. IMA headquarter Dr. Kanak Goyal Award 2018 for exemplary work in women's health and family planning. Apulki Award for work in women's social issues for consecutive 2 years. IMA National and Maharashtra State President's Appreciation Award for 3 consecutive years, and Rotary Award for social outstanding work. Welcome, ma'am.
Yeah, thank you, Sandhya. And this is a very interesting case which I will be reading out. And I hope there will be some comments from all of you also. Actually, this case is about role of valethamide bromide in cervical dilatation. I think we have all been using it since days and years together. So we'll just go through the case so that we can formulate what our opinions are. A 30-year-old pregnant G2P2, that is Gravida 2 Para 1 with previous spontaneous vaginal delivery.
Meenakshi, please share your screen.
Can you hear me?
Can you share your screen? Do you have a PowerPoint
Oh, I
presentation?
couldn't do that.
Yeah.
Can Prasad or somebody do it, because I'm joining out from office.
Prasanna,
It is not
Mr.
downloaded.
Can you share
me
your
try.
screen? Mhm.
हाँ, इथे डाउनलोड नहीं केलं काही.
Yeah.
मला वाटलं हे
Just he'll share the screen. Mr. Prasad, do you have it on your laptop?
Just give me a moment, ma'am. Just give me a moment.
Sure, sure.
Yeah.
Hmm.
Can you make it full screen? Yes. So, yes. So, shall I continue?
Yes,
Can
please.
everybody see the slides?
Yes, Meenakshi, we can see.
Yeah. So, a 30-year-old pregnant woman, G2P1 with previous spontaneous vaginal delivery, was admitted to the hospital with labor pains at 40th week of gestation. She was in the active phase of labor with well-established uterine contractions. There was a labor pain with a frequency of 2 to 3 contractions every 15 to 20 minutes. As per her medical history, there was no significant past obstetric history. She had got one normal delivery. She has no fever or evidence of any infection. Her prenatal records were normal. Her routine screenings and other tests were also within normal range. In the investigation part, the obstetric ultrasound revealed a single live intrauterine fetus in cephalic presentation. The cervical dilatation approached 2 to 3 centimeters with an effacement of 50%. Cervix was irreducible and dilatation of 4 centimeters was observed with slow progression. Next slide, please. So in the treatment part, the resident or the gynecologist did vaginal examinations every 2 hourly to assess the progress of labor and to reduce the duration of labor and for better cervical dilatation and also for a little bit rapid progress of labor. Valethamide bromide was administered intravenously every 30 minutes for 3 doses. Like we give 1 ampule every half an hour for 3 doses. The patient was monitored clinically for uterine contractions, cervical dilatations, fetal heart rate, and maternal vital signs were recorded. After the administration of valethamide bromide, there was a coordinate uterine action. The uterine contractions little bit increased, and it was effective in shortening the duration of labor and increasing the rate of cervical dilatation without any maternal or fetal complications. So next slide. So now I would go on to the discussion, but I would also like some opinions. Labor is considered as one of the most important episodes in the life of a woman. And we, of course, require the patients to go into normal labor. And we also require them to deliver normally within that stipulated time of the partogram without going into the action line and an alert line. So in some patients, even in presence of good uterine contractions, the cervical dilatation may be affected due to inhibitory impulses because of spasms coming, and then this can result in prolonged labor. So efforts have been made in trying to decrease the labor duration without affecting the maternal as well as fetal outcomes. But due to neurotropic and musculotropic properties, valethamide bromide can result in the relaxation of cervical musculature, causing quick dilatation of cervix and maybe shortening of labor. So it's considered as a potentially rapidly acting anticholinergic, spasmolytic, and musculotropic agent that accelerates labor by improving cervical dilatation. There is a 50% reduction in the duration of labor, and it has been reported with a mean rate of cervical dilatation after 3 centimeter dilatation be 3 centimeter. The valethamide bromide can result in reduction of duration of labor, normalization of irregular uterine contractions, and improvement in the process of cervical dilatation. So these are the references which have been given below. And I would like to invite opinions about such case and utilization of valethamide bromide in our daily practice. As for my opinion, I have been utilizing it for in many cases, but I find it improves the cervical dilatation rate. But of course, we need to add some pitocin with that or a misoprostol tablet with that. So that was my opinion. So anybody else's opinion we would like to invite, and the topic is open for discussion.
Nowadays, ma'am, I am not using valethamide bromide. I am using dotaverine every 3 hourly and with the misoprost. So I am having very good progression rate for the normal labor.
Okay.
So ideally speaking, according to the new WHO guidelines, we should not be interfering in any way for all low risk pregnancies. You just have to wait and watch. So active phase of labor is beyond 5 centimeters. So, even up to 5 centimeters, it is considered as the latent phase. So ideally speaking, I think that we should, the process of watchful expectancy is what needs to be followed. And unless there are those stipulated 3 to 4 contractions lasting for more than 45 seconds in a span of 10 minutes time, we do not, count it as proper established active labor. So I think that, we need to really, if we want to increase our rates of normal delivery, the less you interfere, the less you touch, the less you panic. And just because you have a meeting, you have to travel, you are in a hurry, it is not, we cannot do these things. So actually the days of group practice should really be thought about. We really have to think very loudly and clearly regarding all these things, because we have to accept that we do tend to interfere a bit too much, even in unnecessary situations. So, friends, let us, valethamide bromide is a fantastic drug. We've been using it for years together. Rotin is excellent. Misoprostol is excellent. Everything is excellent. But the point is that, is it necessary to use it? Just as Dr. Mino talked about, is it necessary to operate? Is it necessary? If she's getting a reasonably good pain, she's doing well, do we really want to interfere? We all know all these things cause a lot of tachycardia. Your Drotin, your epidocin, all these things cause a lot of tachycardia. There you're going to have the mother's pulse high, you're going to have the fetal heart high. Then you're going to say that the heart rate increased to 160, 170, and now you can see it is dropping to 140. You'll say it is fetal distress, you will interfere. So I think, I personally, I'm in that phase currently that we just don't interfere. We just allow the woman to progress the way she is. And yes, if we see that she's, moving beyond the alert line, then yes, we interfere with our pitocin, we interfere with our valethamide bromide. But till then, believe me, friends, we are having such superb rates of normal deliveries that we genuinely feel that the less you interfere, the less she progresses the more she progresses naturally, you're really going to help to increase the rates of normal delivery and reduce the rate of C-section, which is increasing so alarmingly all across our country. And when we compare it to the Western literature, definitely our rates are significantly higher. I'm not justifying anything about the Western literature or their modes of delivery, but we also have to think as to where we are probably not doing things how they should be done. So that is my take on it.
नहीं, यहाँ पर मेन प्रॉब्लम क्या है ना, पेशेंट को डॉक्टर आप ही चाहिए डिलीवरी के लिए, आप ही चाहिए डिलीवरी. You said group practice, then you want to cut short.
No. I'm into that phase where my group is ready and I'm for the last 3 years now. And I've got a good outcome. So maybe just...
No, I think the topic is not about whether we want to cut short. The thing is whether there is a lot of, slowing down of the labor process.
That is also very difficult. When you're crossing the alert line, then of course you should intervene. But till then, just abhi wo 3 centimeter ho gaya, abhi 4 centimeter ho gayi, ye bitha, wo bitha. This is what even I was doing. And I realized it ended up in a lot of... hypertonicity of the uterus or a little bit of, unnatural responses of the body. So that was just one.
Let the nature take over you.
Yeah, but it was happening all the years for so many.
1 second, 1 minute.
Charu, how many hours we have to wait? That also we have to consider. If the patient is already in the labor and she is not progressing, that means she is not having
Yeah,
a
Dr.
proper
Deepika, that is what we're saying, that after 5 centimeters is she's in the active phase. From 2.53, we start being behind her. Don't. That's all what we feel. We have to, after 5 is active labor. That is a newer definitions by WHO. Not beyond 3 centimeters any longer. So,
in fact, my opinion would be, my opinion would be that you need to, there is concept of active management of labor. After a certain point, dilatation patient is not progressing. You have to actively manage, augment the labor and deliver the patient. Watchful expectancy over 2-3 days is not fair for the patient also. And
we're not talking about 2-3 days, but if she's having good pain,
yes,
otherwise patient
absolutely do not touch the patient is a wrong concept. Wherever indicated, do give epidosine. Wherever indicated, please augment labor with pitocin, and just not touching patient, just let nature take its course. I am not ready to agree with this. We are obstetrician. We are here to relieve the patient's suffering, the pain, and wherever indicated, we have to actively manage the labor.
But even attendants do so much panic.
Not unnecessary. Not unnecessary.
Even the attendants
are so much panic. Pandora's box which we are opening up now.
Yeah, where indicated.
Yeah. Very good.
You were saying something.
Admit the patient and forget her, like that.
No, we have to keep a partogram. That is the correct. Then only thing is what Charu was saying is also, because that is a WHO guideline. Only thing is we should not start it in too early in labor, because even if it is an active labor between 3 to 5 centimeter, we should not start epidosine or valethamide bromide or misoprostol or pitocin. We must let few hours still go by and see how much she progresses naturally before inducing her or augmenting her. So that is, we come to a conclusion that we should not do it early in the labor.
Let us take the opinion of Dr. Rosa, madam.
No, it's really, all of you have given one aspect of the part. Everybody is right, nobody is wrong. But what I would agree with the partogram that Dr. Meenakshi just mentioned. So in my hospital, we have done the Manyata kind of, training that Foxy has done. So my staff are now trained in doing the partogram. So it's very easy when you see after 2 hours, the dilatation is not there. And I would agree to some of you that you say that until and unless it's not necessary, we don't want to give Buscopan and epidosine. Long back, we would say, to Buscopan, ek epidosine intramuscular. We did have good result out of it. Sometimes we have a little postpartum hemorrhage. Then we would have, I don't know if you all have agreed to that, but definitely I would say cardiotocography machine and a partogram should go hand in hand. Unnecessary interventions will lead to C-section. That's why the rate of some of the private hospitals go on the higher side. But definitely we need to have actually in India midwifery. What we lack in India is good midwives who would do the monitoring of the patients. And the obstetrician should come into the picture when it's going to be on twos delivery, forceps, or there is any intervention. Everywhere else in the world is when the midwives are doing the deliveries. But here, as you correctly said, Charlotte, you have to only be dependent on the obstetricians. And how many hours can an obstetrician be looking after the patient? So my suggestion would be a good partogram, monitoring, and again, a teamwork. It's not easy to be single-handed and doing all these things nowadays, especially when there is medical legal issues. Yeah.
Just have a question, Rosa madam. Suppose a midwife delivers the baby while the patient is under the care of an obstetrician and there is some complication happens. Is the midwife responsible or the obstetrician responsible?
So I don't know what the rule is here. I was for some times in Australia during my fellowship. So what happens in Australia is when we are on duty on the birth suite, it is the midwife who monitors the patient with a partogram. It is in the birth suite and the cardiotocography goes on. The moment there is a fetal distress, the moment she sees that there is some problem with the case, no more the midwife is responsible. It's the obstetrician who's called and will be responsible. So there is no kind of, complications with the patient. In India also, I'm sure once if we start having midwives, if we can have trained midwives for normal delivery, as long as everything is okay. So what is a proof for them? The proof to the midwife would be a cardiotocography, the monitoring, everything is okay, no fetal distress, dilatation is good, the partogram is next to the, the patient. So as long as everything is normal, fine. It is a midwife who can do it. But the moment she sees there's a fetal distress or there's a little bit of problem with the partogram, it's taking too long to dilate, that is a time the obstetrician has to be responsible.
Her net is not working.
Am I audible? Am I audible?
Oh, yes. Oh, yes.
Yes, very well said.
Now we
Very
are.
well explained, yes.
Yeah. So we need to, somehow, Foxy President, I think, or the Vice President to be, where is Dr. Minu? Take this up. This is why I'm going to pull your leg. I think that, when Dr. Jaydeep was the president of Foxy, many years back, she did talk about midwifery. We were together, I remember, I was closely working with her for this, but it didn't work out. The government of India needs to work for it. We need to literally, push ourselves for midwives. I think then the obstetricians can take care of 1-2 delivery, applying forceps and coming to that stage. That is us. We should come to the picture if there is any non-progressive labor, or a C-section has to take place. Yeah.
Right.
Pearls of wisdom, Rosa ma'am.
Thank you.
So wonderful to hear all this advice from you.
Thank you. It's just a
Especially
suggestion.
a controversial topic like this and a day-to-day topic, which is very much useful for us.
I'm so happy you're having case discussion. I think this is a very good thing. And I'm sure my vice presidents I see here and Snehlata, we can do this in our GOGS also, Gwalior Obstetric Gynec Society. Each CME should have such case discussions, which are practical, which all the obstetricians should do, not very hi-fi things, just practicality, which is very good for you. Pune is doing excellent. We are learning
For
from
the
it.
daily practice.
It's always a learning thing. Yeah. So I think we've come to the end.
Thank you, Dr. Minu, Dr.
Yes.
Vaishali.
Thank you, Meenakshi ma'am, for such good discussion. Thank you. Thanks a lot.
After this discussion, which is very close to our heart, it was
Yeah.
very evident that we are obstetricians at heart, even if we do infertility, laparoscopy. So yes, now I request Vaishali ma'am, Charu ma'am to give her vote of thanks.
Yes, indeed. It is such a pleasure to say a big thank you to Gwalior and Jabalpur OBGYN societies on behalf of the Pune OBGYN Society, which has hosted the Cutting Edge webinar, a brainchild of Dr. Meenu Agarwal. We are so happy to have had Dr. Rosa Olyai and Dr. Kavita Singh, who unfortunately could not join as our guests of honor. Thank you, Dr. Rosa, for your presence as guest of honor also, and for all those valuable inputs and suggestions that you gave. Looking forward to meeting you more often, Dr. Rosa.
Thank you.
Thank you. I thank Dr. Snehlata Dubey, Secretary GOGS, Dr. Deepti Gupta, Secretary of
Charu, we don't see you suddenly.
Disconnected.
Yeah.
I think she's got disconnected. Vaishali ma'am, can you please do the honors, ma'am? Can you please give the vote of thanks?
Yeah. So like Charu was saying, we are really deeply indebted for presence of Rosa ma'am as a guest of honor, and Gwalior and Jabalpur OBGYN Society for associating with us. And we had such wonderful talks by our three speakers, Dr. Meenu Agarwal, Dr. Anju Verma, and Dr. Meenakshi. Thank you very much. Truly very educative and very interesting talks. And our chairpersons, thank you for our chairpersons, Dr. Snehlata Dubey and Dr. Deepti, and also Dr. Preeti, Dr. Jigyasa. Thank you for being with us and for chairing the sessions and for your valuable inputs. Your presence has truly enriched this webinar, and it has fulfilled a quest for spreading knowledge. That's what we have been aiming for. Thank you to all the delegates who have logged in, and a special thank you to Dr. Sandhya Meshram for coordinating everything, and to Mr. Prasad Kulkarni from BSV for working and coordinating and making this academic platform. very successful. So truly an honor to all of you, and thank you once again, heartfelt. Thank you.
Thank you.
All the very best, Minu, again.
Thank you
Vishali,
so much. Thank
lovely
you.
to see you.
Ma'am. Lovely to see you, ma'am.
Okay, bye. Bye,
Thank you,
Anju.
Rosa ma'am, and all the Dr.
Thank-
Meenu. Thank you. Bye.
Bye.
And all the best to Dr. Preeti Gupta for her
Dr. Dipti.
Yes.
committee chairperson elections.
All the best.
Sandhya, you did a good job as a MOC.
Thank you, ma'am. Thank you.
Thank you. Bye. Take care. See you all. Bye-bye.
Bye. Minu, Prasad.